Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Studies have shown that as much as 15% of operating time is lost when a patient must sit up, rinse, and expectorate using the traditional cuspidor without the benefit of a high-velocity evacuation system. The operator must remove isolation materials, rinse the area, and allow the patient to sit up and eliminate the water. After the rinse is completed, isolation must again be established. Compare this technique with a typical rinsing procedure utilizing a chairside dental assistant and a high-velocity evacuation system. Considerably less time is needed for the assistant to rinse and evacuate the patient's mouth. The procedure can continue with little disruption. Attempts have been made to control fluids in the oral cavity using only low-velocity evacuation, such as a saliva ejector. However, this method is somewhat limited in its effectiveness. The saliva ejector removes only liquids and must be completely immersed in the fluid for removal to be accomplished. The saliva ejector is not effective in the removal of solid debris, such as amalgam particles in dental cement, or in extreme posterior areas where fluids accumulate when the patient is supine. On the other hand, when a high-velocity evacuation system is used, the tip does not have to be immersed in the liquid for removal to be accomplished. Debris such as cement and amalgam is easily removed. As a result, high-velocity evacuation systems are more effective and are recommended. There are many types of evacuator tips available in both metal and plastic styles. When selecting an evacuator tip, consideration should be given to the area of the oral cavity being treated. This will determine if the evacuator will be used as a retraction device or to simply remove fluids. The diameter of the opening of the tip must be large enough to remove the large volume of water and debris associated with cavity preparation. The universal tip can be used effectively in all areas of the oral cavity and is generally the tip of choice. The tip is available in both metal and plastic. Both may be autoclaved. Effective evacuation is accomplished in anterior as well as posterior areas. The plastic tip is generally preferred since the metal tip is often too cold for patient comfort. Plastic tips are also recommended for use with electrosurgery units for patient safety. The evacuator is held in the assistant's right hand when working with a right-handed operator and left hand when working with a left-handed operator. There are two methods commonly used for holding the evacuator. The thumb-to-nose grasp is preferred when working in posterior areas. The assistant's fingers are spread over a large area of the evacuator, and the thumb points toward the assistant's nose. A finger may be used to turn the suction on, and the thumb is used to turn the suction off. This grasp provides maximum control of the evacuator and facilitates retraction of soft tissue. The modified pen grasp is recommended when using the surgical suction tip, or when maximum retraction of soft tissue is not required. The universal tip is most commonly used because it is adaptable to all areas of the mouth. Let's examine the universal tip and its proper positioning in the oral cavity. The universal tip has an anterior bevel and a posterior bevel. When positioned in the oral cavity, the tip of the evacuator is generally parallel to the buccal or lingual surface of the tooth to maximize airflow into the suction tube. When positioned correctly, the tip should bend toward the assistant's body, thereby keeping the assistant's hand out of the path of the light. When the tip is positioned incorrectly, using the anterior end in a posterior area, the tip bends toward the operator. The assistant's hand now blocks the light and decreases the operator's visibility. The correct orientation of the tip provides convenient access to the operative field, effective removal of fluids and debris, and enhances visibility for the operator. Let's look at the correct evacuator tip placement for the 6 segments of the oral cavity. When working in the maxillary left posterior area using a buccal approach, The posterior bevel of the evacuator tip is positioned along the occlusal surface of the teeth with the opening directed toward the handpiece. After the evacuator has been placed and retraction of soft tissue is accomplished, the operator places the handpiece. If the preparation is on the occlusal surface of the teeth, the evacuator is oriented with the posterior bevel parallel and slightly distal to the tooth being treated. The tip of the evacuator extends just above the occlusal surface. The lingual surface is approached with the evacuator tip on the buccal surface opposite the area being treated. Notice the bend of the evacuator tip goes toward the assistant. The labial surface of the maxillary anterior teeth is approached with the anterior bevel of the evacuator placed on the lingual surface parallel to the tooth being treated. Half of the tip of the evacuator extends beyond the incisal edge. The patient's lip may be either retracted with the operator's finger or supported with a cotton roll. If an incisal approach is used, the evacuator is placed on the labial surface with the anterior bevel opposite and parallel to the tooth being treated. The position of the evacuator tip remains the same when the preparation is extended to the lingual surface. When working on the buccal surface of the maxillary right posterior segment, the evacuator is placed with a and slightly distal to the tooth being treated. Half of the opening of the tip extends beyond the occlusal surface. The tip remains in the same relative position when the preparation is on the occlusal surface. However, it isn't necessary for the opening to extend beyond the occlusal table. When treating the lingual surface, the tip is positioned distal and parallel to the preparation. Treating the mandibular left posterior segment requires retraction of the cheek by the dental assistant. When using a buccal approach, the posterior bevel is placed parallel and distal to the area being treated. If the preparation is on the occlusal surface, the tip is positioned opposite the area being treated. Use of a hygoformic facilitates retraction of the tongue. The opening of the tip is moved slightly above the occlusal surface when a lingual approach is used. The anterior bevel is used when treating the mandibular anterior area. If the preparation is on the labial surface, then the evacuator tip is positioned on the lingual opposite the area being treated, with half of the opening of the tip extending above the incisal edge. When an incisal approach is used, the evacuator is positioned on the labial surface opposite the area being treated. The position of the evacuator tip remains relatively the same when treating the lingual surface. However, the opening of the tip should be moved to extend slightly above the incisal edge. The posterior bevel is positioned on the lingual aspect of the teeth when preparing the buccal surface of the mandibular right posterior segment. The assistant retracts the tongue with the evacuator tip, or a hygoformic may be used for retraction. The opening of the tip should be held parallel to the tooth structure to avoid aspirating soft tissue. Half of the opening of the tip extends beyond the occlusal surface. The position of the evacuator remains the same when the preparation is on the occlusal surface. When treating the lingual surface, the evacuator is placed distal to the preparation. It may be necessary to use intermittent evacuation in the more posterior areas. Correct placement of the evacuator is of the utmost importance if optimum efficiency is to be achieved. The access and visibility of the operator must be of prime concern when intraoral procedures are being done. Let's review the basic guidelines for suction tip placement. Hold the tip with a thumb to nose or modified pen grasp. Position the tip before the handpiece to facilitate better access and visibility for the operator. Position the tip distal to the tooth being restored. Position the opening of the tip parallel to the buccal or lingual surface of the teeth. Position the opening of the tip slightly above or even with the occlusal surface. Special evacuator tips have been designed to deal with specific problems encountered with oral evacuation. Let's look at a selection of evacuator tips commonly used for oral evacuation. The surgical suction tip is ideal when access is needed in a surgical setting. The tip is small enough to be placed in the surgical area without obstructing the operator's view and without traumatizing the surgical site. Because the orifice of the tip is very small, this tip is not recommended for use with a high-speed handpiece, since the volume of water is more than can be effectively removed with a small tip. However, the small tip is ideal for localized evacuation of the surgical site. The spoon-shaped evacuator tip is often helpful when working in the mandibular right posterior area where retraction of the tongue is essential. The assistant uses her right hand to evacuate and retract, leaving her left hand free to exchange instruments and operate the air-water syringe. A modification of the spoon tip is the flange tip. The metal shield aids in the retraction of the tongue, but may be a bit uncomfortable for the patient. The disposable plastic tip is rather short and very flexible. For this reason, its use is limited to areas that require little or no retraction of soft tissue, such as the maxillary right posterior area or the lingual of anterior teeth. Oral evacuation is one of the most important skills to be mastered by the dental assistant. Effective use of this skill contributes significantly to the successful practice of four-handed dentistry.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.